Good afternoon, friends. My sincere thanks to Professor Aggarwal, Dr. Pawan Gupta, and his whole team. And of course, most importantly, the audience which is sitting, despite the fact that they've been sitting here right from 8 o'clock in the morning. I shall be very brief to the point and shall not beat anything about the bush and just convey the message that I wish to convey. The topic is diabetes in 2012. It doesn't mean that I'm going to discuss the ADA recommendations which are there, which have come recently, but how I would like to treat diabetes in 2012 and how I would like my friends to treat diabetes in 2012. We have to concentrate not only the fasting glucose, the postprandial and the HbA1c, but move on to the fourth dimension, and that is the glucose variability, and produce a good HbA1c, not a mean of very low and very high, and then achieving good results, but by minimizing the variability so that the long-term complications are minimum. Many studies recently have confirmed that if variability is less, the long-term complications, both micro and macrovascular, they are much less. And to quote this particular study, and of course another study, which is a long 14-year study presented by Italian workers, that postprandial blood glucose and not the fasting, they predict cardiovascular events and all-cause mortality. And I've straight come to the conclusion that despite this long 14 years, they came to the conclusion that it is a glucose variability which is responsible for various complications. Therefore, the pre and post meal values are equally important, and what is probably more important is one may have a baseline of around say 120, 130, 140, but if variability is around 50 or 60 mg/%, the complication rate will be much less as compared to a person whose HbA1c may look excellent like say 6.5, but if variability is more, the complication rate or what we truly want to achieve is worse. Now, this is what is the therapeutic definition of diabetes, that this is a state of insulin insufficiency. If it's absolute, it's type 1. If it's relative, it's type 2. Now, what causes it? In this situation, there is increased requirement of insulin and there is decreased availability. And how do we treat it? Decrease the requirement of insulin and improve the availability of insulin. And these are various groups of drugs. I shall be very briefly discussing about them, mainly talking about a new drug which is going to be available very soon, which has got few better effects, and then another drug, again just touching only, which is going to be approved by the FDA possibly within this year only. The main purpose of treating diabetes is to prevent the beta cell loss so that the beta cell mass doesn't follow a downhill course but possibly gets arrested, or if possible it can even improve also. So any drug that can improve the beta cell mass can provide a very comprehensive glucose control with minimum fluctuations. In addition to this, there are multiple challenges. We know that hypoglycemia, it is associated with weight gain, and all those factors that drugs, they lose their efficacy over a period of time because of the dying beta cell mass. And of course, complex regime, cardio safety, and frequent monitoring which is required to maintain a good glucose control. Many drugs that we know about them are that the worst problem that we face in controlling good glycemic control or achieving a good glycemic control is hypoglycemia. Any drug which produces hypoglycemia is going to create multiple problems. It is going to increase the weight gain. It is going to create bigger problems as far as the heart is concerned, and also the variability is going to be much more. I should like to mention that drugs, especially sulfonylurea or insulin, they are the worst as far as hypoglycemic events are concerned, and they are the one which create bigger complications like weight gain. But in addition to that, there are other group of drugs which are insulin sensitizers and AGI, etc., which don't really touch the basic pathophysiology. They try to improve the insulin sensitivity, they slow down the glucose absorption, and then they produce the results. But the incretin group of drugs, they are the one which have got minimum hypoglycemia. If they use alone, these are almost negligible. And they are neutral as far as the weight is concerned, and with incretin, weight loss can also be there. But in addition to that, the glycemic durability is much better. The beta cell mass may even improve, and postprandial excursions are also minimal. Thus, a combination of glucose sensitizers, insulin resistance breakers or insulin sensitizers and incretin-based therapies, if we combine together, we can truly achieve what we want. Now, so far we are used to this particular slide or a few other slides which have been showing that in animal studies, if you use the GLP-1 group of drugs, we can improve the beta cell mass, but so far there was no evidence that in humans this can happen. This has been questioned by many authorities that there is evidence in human beings. Of course, in human beings so far evidence was lacking. But indirect evidence that the insulin requirement will go down, the secretogogue requirement will go down, that has been existing. But here I quote a study which was presented just a few months ago in ADA, that comparison of Aggarwal 4 on the beta cell replication in both mouse and human islet cells. And I shall very briefly come to the points only. In this very well formed study, the mice was rendered diabetics with streptozene. That means the beta cells were destroyed. Now, in one group, the mouse islets were implanted in the mice, and in another, the human islets were planted into the mice. And then they saw the results that in the mice islet, there was significant improvement. But what about the human beings? Even when the human islets were transplanted into the mice, there was marked improvement in both untreated group and significant improvement in the treated group, which was treated with Aggarwal. Thus, thereby showing for the first time that islet cell replication can increase under the influence of GLP-1 in the human islets also. So that gives a great consolation. The drug that we've been using for the last 2 years, we are on the right track. So the group of drugs, they belong to two categories, including mimetics and DP4 inhibitors. But I shall today very briefly mention about a newer DP4 inhibitor, that is linagliptin. This linagliptin is very rapidly absorbed and reaches a peak of around 1.3 to 1.5 hours. And it is not metabolized in the body. Almost 90% is excreted, almost unchanged completely. And around 85 to 90% is excreted via enterohepatic circulation and is out, and in the urine around 5% is removed. So this gives a greater confidence that possibly that in case there is any renal insufficiency or hepatic insufficiency, possibly this group of drugs may be safer. Advantage is that it got very long half-life, that is around 130 hours, but accumulation problem is not there. And not only that, it's a very weak competitive inhibitor of the CYP group of enzymes, which lead to various drug-to-drug interactions. And in patients with renal insufficiency of whatever degree, mild, moderate, or severe, since it is not excreted through kidney, so it doesn't affect the metabolism of the drug. And not only that, even as far as the liver failure is concerned, it is just excreted unchanged. So it doesn't, it is not affected by any degree of liver failure also. So a great consolation that whatever the state of liver or kidney, this drug is going to be effective in performing its role in the management of type 2 diabetes, and thus it forms a very suitable option for patients who are suffering from whatever degree of renal or hepatic insufficiency. Just to compare all the gliptins which are presently available and the one which is going to be available, dose of course is no concern, whether it's 500, whether it's 5 or it's 100. Oral bioavailability of this is rather low. It's around 30% what we absorb. But that makes no difference to the patient as long as it's effective. Its half-life is very long because it's very tightly bound to the proteins. And active metabolites are not there. And renal excretion is just around 5%, not affected by the renal or kidney problem. And drug-to-drug interaction is also not there. And again, as far as the CYP inhibitors are concerned, it's not affected. So it has got few additional advantages as compared to the other gliptins which are available. However, as far as the efficacy is concerned, probably is going to be same. Only thing is that dose adjustment is not required, so convenience of giving this new gliptin may be there. It is this one that no dose changes as far as the kidney is concerned, as far as the liver is concerned, that makes us happier that probably this is the one which is going to be comparatively safer. Another drug which came with a bang about 2 years ago, then there was thought that probably it may cause bladder cancer or some urinary tract infection. The information is being revised and it's likely to be approved possibly within this year only by the FDA. The drug has got a great potential, maybe short term, and that is by this information that proximal convoluted tubules, they reabsorb around 90% of the glucose, and if we need to throw away this additional glucose in a person who could be either obese or when the blood glucose is very high, in this situation, this SGLT2 inhibitor may help us to throw away glucose without truly worrying that it may cause increased frequency of infections, etc., which has been really almost ruled out. So coming back to the practical aspect, that if we want to treat diabetes, we must make use of drugs which decrease the insulin requirement and also take help of those selective group of drugs which make the insulin more insulin available. So all the drugs which decrease the requirement, that means insulin sensitizers, metformin, especially in the early stages, glitazone also, alpha glucosidase inhibitors and SGLT2, they could be used to reduce the requirement of insulin. And if you can combine this group of drugs with the group of drugs which act in a very multiple fashion, like GLP group of drugs, whether it's DPP4 inhibitor or injectables, if you combine them right in the beginning, the long-term results are going to be good. But if you find that initially the glucose is on the higher side, and we know the glucotoxicity must be tackled with all the force, in that situation, we can take help of either insulin or long-acting secretagogues. But long-acting insulins are much better because they won't really tax the already exhausted beta cells. And once the glucose control becomes adequate, one may switch back to a combination of the groups of drugs which decrease requirement, that is with the help of sensitization, etc. And also at the same time, using DP4 inhibitor groups which will maintain the beta cell mass, which will help in improving the insulin secretion and also having action at the level of the stomach, the brain, and also by suppressing glucagon. So by all the mechanism, it is going to help. But their maximum advantage is that if you use them early, when the beta cell mass is, say, close to around 50%, then it can be easily maintained. The later they are used, their efficacy may gradually go down. So friends, to end of my talk, my message to my friends is that we must use all the possible drugs which are really good as far as the beta cell friendly. So early and aggressive glycemic control is very important, because it also creates a sense of discipline in the patient. That is, the doctor right in the beginning is going to be strict that you have to achieve a target, then he is going to follow, and then of course the complication rate can also be reduced. Insulin has got best results in the long-term basis, right, if it's used in the beginning, rather than at the end when the beta cell is exhausted. The true role is to tackle the glucotoxicity and not to act as a replacement. And if it's used in the beginning, it may be required for a short while. That short while could be as short as around 1 week or even 2 weeks also. And once you have tackled glucotoxicity in a proper way, the other drugs which are doing something like a massage, etc. for the beta cell, they'll continue to work and continue to work for a very, very long time without any exhaustion, and they'll maintain the durability. We must make full use of insulin sensitizers. A good dose of insulin sensitizer, whether it's metformin or especially even the glitazone, they're very good, especially initially. And one shouldn't be really worried because the dose required to produce bladder cancer, etc. is much higher. We can use them for 6 months, 1 year, 2 years, much say below that the dose of around 28 grams of pioglitazone, and give the best results right in the beginning so that the long-term results are best. And we should use the beta cell friendly drugs which I refer to, the incretin group of drugs, that is DP4 inhibitor or injection. They must be used early so that we can preserve the beta cell mass. And of course, finally, it is equally important to control the blood pressure, the lipids, the weight reduction, smoking cessation, and of course, lifestyle modification. If we follow these 5 principles, we can produce the best results, reduce the complication, and reduce the misery in our patients. Thank you very much, my dear friends.